In December 2019, China notified the World Health Organization of several cases of human respiratory illness, the disease later named COVID-19.
Please insert password. Access denied.
Hi, Assalamualaikum, I'm Z Farmers, and today I'll be discussing about COVID and its relation to cardiovascular. Related literature in COVID-19 and cardiovascular disease, from basic mechanism to clinical perspective. But before we head to our topic, what is coronavirus? It is large family of viruses that cause illness ranging from the common cold to more severe diseases such as SARS-CoV from 2002 and MERS-CoV from 2012. Moving on to novel coronavirus, also known as nCoV-19 or COVID-19. Last December 2019, WHO Regional Office in China was informed of cases of pneumonia of unknown cause detected in Wuhan City, China, which is later on January 7, 2020, it was identified as COVID-19, the new strain of coronavirus. It is believed that COVID-19 originated in animals such as seafood, which were found in Animal City Market in Wuhan. The transmission of the virus can spread from infected person to another person through close contact without percussion. Here, the symptoms of COVID-19 includes and varies from on and off fever, chills, cough, shortness of breath, fatigue, muscles and body aches, sore throat, diarrhea, loss of taste or smell, headache, or some develop pneumonia. If you have the symptoms, go see a doctor. COVID-19 and cardiovascular disease. Several clinic studies have reported CVD as the most common cause of morbidity in patients associated with COVID. Pre-existing cardiovascular disease seems to be linked with worse outcomes and increased risk of death in patients with COVID-19, whereas COVID-19 itself can also induce CVD complications. Potential drug disease reactions affecting patients with COVID-19 and comorbid cardiovascular disease are also becoming a serious concern. COVID-19 with pre-existing CVD. Severe symptoms of COVID-19 are more common in patients with pre-existing CVD when became infected. Therefore, a large proportion of deaths from COVID-19 have resulted among those patients. A meta-analysis of 1,500 patients with COVID-19 showed that patients with cardiac disease, which is 16.4%, and hypertension, which is 17.1%, were more likely to require intensive care. Studies reported that patients with hypertension and CVD have higher expression of angiotensin-converting enzyme, which could be a potential reason for enhancing susceptibility of those patients to SARS-CoV-2. A possible mechanism pathway of severity between COVID-19 and CVD, alongside patients with CVD are more likely to have hypercoagulability due to increased level of D-dimer, which increases the risk of pulmonary embolism, therefore hypoxia and heart failure. Also in patients with acute coronary syndrome, reduced cardiac function has been observed leading to myocardial ischemia, which might act as a factor to worsen the condition of patients with COVID-19 and may lead to death. CVD induced by COVID-19. Angiotensin-converting enzyme 2, a membrane-bound aminopeptidase, identified as a functional receptor for SARS-CoV-2. The spike protein of SARS-CoV-2 binds to ACE2 and those trigger the infection, which is highly expressed in lungs and heart. So angiotensin 2 converted from angiotensin 1 by ACE, responsible for vasoconstriction, increased blood pressure, and vascular remodeling. Clinical observation revealed significant elevation of plasma angiotensin 2 in a patient with COVID-19, which suggests that binding of COVID-19 to ACE2 causes a release of excessive angiotensin 2 through the renin-angiotensin system, RAS, increasing heart loading, cardiomyocyte hypertrophy, and high blood pressure. Invasion of the virus to the lung surface cells and cardiomyocytes causes inflammation and the release of pro-inflammatory cytokines by the overacting immune response of the body and increase apoptosis of myocardial cells, which enhance the risk of cardiovascular events. Besides the activity of pro-inflammatory cytokines, the myocardial dysfunction could be caused by severe lung failure because of the infection and reduce the amount of oxygen supply or hypoxemia. CVD compilations associated with COVID-19, myocardial infarction, and myocarditis. Acute myocardial injury, as evidenced by elevated levels of cardiac biomarkers, or electrocardiogram abnormalities, was observed in 20% of patients with COVID-19. The presence of myocardial injury was associated with a significantly worse prognosis. Other predictors of myocardial injury included advanced age, presence of comorbidities, and high levels of C-reactive protein. Patients with myocardial injury who had elevated high-sensitivity levels of cardiac troponin, plus abnormalities on echocardiography and/or electrocardiogram did not have typical signs of myocarditis, such as segmental wall motion, abnormality, or reduced left ventricular ejection fraction, suggesting that myocardial injury was secondary to systemic causes rather than a result of direct viral infection of the heart. Given that SARS-CoV and SARS-CoV-2 share the same mechanisms of entry into the host cell, it might help us determine whether SARS-CoV-2 can infect cardiac cells directly, and that the heart expresses high levels of ACE2. A marked increase in macrophage infiltration with evidence of myocardial damage was also detected, suggesting that SARS-CoV can really infect the heart directly. Taken together, studies suggest that myocardial injury is not only a common manifestation of COVID-19, but also a risk factor for poor prognosis. Myocardial injury seems to be largely attributable to advanced systemic inflammation. It might also infect the myocardium directly, resulting in viral myocarditis. Number 2. Acute coronary syndrome, ACS. The incidence of ACS in patients with COVID-19 is still unknown. The mechanisms underlying COVID-19 induced ACS might involve plaque rupture, coronary spasm, or microthrombi owing to systemic inflammation or cytokine storm. Activated macrophages are also known to secrete tissue factor, a potent procoagulant that triggers thrombus formation when the plaque ruptures. Direct endothelial or vascular injury caused by SARS-CoV-2 infection might also increase the risk of thrombus formation and ACS. Number 3. Heart failure. Heart failure could occur due to exacerbation of prior left ventricular dysfunction. Given that patients with COVID-19 are likely to be older and to have pre-existing comorbidities, such as coronary artery disease, hypertension, and diabetes, heart failure might be the result of exacerbation of these pre-existing conditions, whether already diagnosed or unknown, or the uncovering of subclinical cardiac dysfunction. In particular, elderly patients with reduced diastolic function might develop heart failure with preserved EF during the course of COVID-19, which can be triggered by high fever, excessive hydration, and impaired renal function. Number 4. Cardiac arrhythmias. The exact contribution of COVID-19 to cardiac arrhythmias remains uncertain given that arrhythmias such as atrial and ventricular tachycardia and fibrillation can be triggered by myocardial injury or other systemic causes such as fever, sepsis, hypoxia, abnormal metabolism, electrolyte abnormalities, or inflammatory stress induced by COVID-19 infection. Furthermore, patients with advanced COVID-19 are often treated with antiviral medications and antibiotics that are known to induce arrhythmias in some patients. Number 5. Venous thromboembolism. Due to excessive inflammation, immobilization, and diffusive intravascular coagulation, DIC, COVID-19 may lead to venous thromboembolism. COVID-19 is associated with coagulation abnormalities, which can result in thromboembolism events. Patients with COVID-19 often have elevated levels of D-dimer, modestly reduced platelet counts, and slightly prolonged prothrombin in time. A study suggests that anticoagulation therapy with low molecular weight heparin may reduce mortality in patients with severe COVID-19 infection. Venous thromboembolism, which includes deep vein thrombosis and pulmonary embolism, is a common complication in critically ill patients with COVID-19. Of note, certain antiviral medications and investigational therapies given to these patients might promote thrombosis or bleeding events through drug and drug interactions with antiplatelet agents and anticoagulants. COVID-19 makes the blood thicker, which makes the body prone to thrombus formation. It may be DVT, myocardial infarction, cerebral infarction, or most likely pulmonary embolism. It is that severe inflammatory response and endothelial damage induced by COVID-19 in combination with underlying comorbidities might predispose patients to a hypercoagulable state. And that will be all for this topic. I hope you've learned something new between the relation of cardiovascular and COVID. And just a reminder to everyone to always stay at home, wear your mask, apply social distancing, wash your hands, and don't touch your face. That'll be all. Thank you for watching and stay safe.